Now we're going to talk about the posterior aspects and structures that you need to be able to palpate and identify when we're talking about the knee. We've talked previously about the hamstring tendon. So the bicep femoris is your lateral most muscle, and then we have our semitendinosus with the real long tendon, and it's kind of the more like centralized to the leg and superficial of the semitendinosus and semimembranosus, the semimembranosus being the bigger muscle and deeper muscle with the bigger membrane. That's why it's called semimembranosus, and the semitendinosus has the really long tendon, which is what allows it to get all the way down to the pes anserine. So just as a reminder, when we're thinking about the knee, these muscles are all going to help with knee flexion. So as they're going to pull their knee up, and when it's centralized, if they do that and I resist, I should be able to feel all three of those hamstring muscles get nice and tight. Now, if I ask the person to externally rotate their lower leg and I resist, you're going to look at these different tendons and you're going to see a difference between them sticking out. Notice when we do external rotation, we see a lot of this biceps femoris come out. And then when I do internal rotation and resist, I can see this semitendinosus tendon really stick out. And that is just because we're doing internal and external rotation of the lower leg, which I think is important for people to understand, that you can isolate these a little bit more. And as I do internal rotation, I'm also looking at the semimembranosus, but it doesn't have that big tendon that's just gonna really jump out at me. In between those tendons, you're going to have something called the popliteal fossa. And if I just passively bring him up and ask him to relax, you're gonna see that it kind of caves in a little bit. And this structure, mostly it has a lot of fat in it because it's a protective thing, because what we have is our femoral artery that comes down and it becomes our popliteal artery here. And you need that fat there to be able to protect it, because otherwise every time you hit the back of your knee on something or somebody kicked you or something, you could potentially be causing damage to that artery, which is bad because that artery is the only way that you get blood to your lower leg. So you should be able to gently push in their lower leg and be able to assess their pulse here. So if they have an injury from their hip down to their knee, remember we need to assess pulses distal to the injury site. So if I have a dislocated hip, a femoral fracture, something like that, I would come here to the popliteal fossa first to see if I can feel the pulse. And then I can come down and either do cap refill, or we'll talk about some of the other areas where we can assess pulse distally in the leg when we get to the ankle and lower leg information. The last structures that we're going to talk about are going to be your gastrocnemius. So it's the most superficial of your calf muscles. These are also biarticular muscles, just like your hamstring muscles are. And so with these, you have a lateral head and a medial head, because they come up and they split, and they're going to both come up and originate on both your medial and lateral femoral condyle. They help a little bit with knee flexion, but of course they're going to be primary plantar flexors, meaning that you point your toes with these muscles in the lower leg. But you should be able to palpate them because they are structures that help with the knee and cross the knee. So what you would do is ask your patient to just actively flex their leg a little bit, and you should be able to feel some contraction of these. And then you would ask them to push their toe like they're hitting a gas pedal, and then you should really be able to follow these gastroc heads as they come and they cross the knee joint. Now, if I want to focus on one versus the other, again, I can have them internally or externally rotate their lower leg. So if I have him externally rotate his lower leg with it flexed and then push, notice this medial gastroc head is going to really stick out. And then if I have him internally rotate and push, now this lateral gastroc head is really going to stick out. And that's going to help you identify which one of these is maybe causing the problem, and are we talking about it from the gastroc or from the knee. And in truth, when we really want to look at the gastrocnemius, it's really best to do it with their knee in extension, because that is when this muscle is fully stretched here and this muscle is fully stretched here. So again, we can go into external rotation and ask him to push really hard, and we should be able to see the muscles kick up. And then we go into internal rotation and we ask him to push, and we see the muscles get tight here as well. So you can assess the gastrocnemius if you're trying to differentiate between the hamstrings and the gastrocnemius, which one is really causing that posterior pain, by having to do both of those tests. Do it with the knee slightly flexed and then with the knee straight. And we're looking at our palpations and we're finding, is the pain coming from this way or is it coming from this way? And then also really talk to them about their history and their mechanism, because hamstrings are going to be a lot more of a stretch and probably they were running or cutting. And then when we talk about gastrocnemius, we're talking more again about a stretch, but more in I had a fast dorsiflexion kind of thing, or something going on with the lower leg and where they're experiencing the pain. If it's hamstring, plantar flexion and dorsiflexion shouldn't bother them at all. If it is their gastrocnemius, those kinds of motions, either active or passive, will aggravate the gastroc. So knowing how to differentiate between these is going to be very important as you're going through these various tests and assessing these various muscles.